We are going to begin the session by looking at some of these photos, just to bring the topic into perspective. When you look at this photo, it looks quite innocent. It's a beautiful African child. As some of us have gone through these lives, we've grown up as these kids to become doctors, engineers, even the president. If you know Mr. Therefore, he also went through similar circumstances. Trachoma is a disease that is quite endemic in African settings. Like most diseases love the equator, it also loves the equator for particular geographical reasons. This is another child, very beautiful. But there is something striking between the two children. The third, and even more. When these children grow into adulthood, they will enjoy their adulthood like this. We are from the Department of Ophthalmology, so let us pick interest in the eyes. So some of these pictures are really to stimulate you to see where we are going, a journey that we are going through, because trachoma is a disease with a journey. I want to remind you that a normal person should have a clear cornea, clear as in totally clear, like a very new glass. So if this is the cornea, this is not clear anymore. So let's start. The lecture was supposed to be delivered by Dr. Ruvuma. He's my supervisor. He is done. So it is a disease that is affecting the world, and it is a preventable infectious disease that causes blindness worldwide. The key word I want you to know is infectious, because there are other leading causes of blindness that are not infectious. So among the infectious causes, trachoma is the leading cause. Also, for those of you online, I want to tell you, in the world of today, trachoma is not so prevalent. It is not so common. In your practice, you may never see trachoma. So when you qualify and you go to the community and you see the eyes, please don't simply write the word trachoma. Think twice, because it has prevention and the world has moved on, as we shall see. So it's a disease that probably in your career you may not see. And those of you who are unfortunate to go and practice, as you remember, doctors practice all over the world, you may go to communities where trachoma is endemic. It is very contagious, and it's a disease that grows with you. You acquire the infection in childhood, but the effects are noted in adulthood, probably in the elderly group. This is the journey. This is a child who acquires infection. This infection spreads from person to person. You become teenagers, you go through school. You are carrying your trachoma and probably it keeps on reinfecting you. You become an adult, you start practicing, you start a life, you start a family, you get married, you produce children, and then the effects start coming. When you get, the eyelids get scars, that is when the problems start. Then the cornea will lose its clarity, and eventually in your old age or in your adult age, you get blind. So that's the journey of trachoma. It's not a disease that is going to bring the worst effects in 2 weeks or 2 months. Yes, we can see it when it is early, and that's the purpose of this lecture, so that you can either prevent it or treat it in this stage here before it finally leads you to the blindness stage. Trachoma almost always affects both eyes, and the symptoms begin when they are mild. Really, you begin with a mild itching or an irritation in eyes. It's a disease that commonly affects the eyelids. The cornea is affected as a bystander. So it's a disease that affects the corneal, the conjunctiva. The conjunctiva is a mucous membrane lining the either eyelids or the eyeball. So the cornea, which is so important in the eye, is affected as a bystander. It's not the primary organ that is affected by trachoma. So all these symptoms of mild itching, irritation in the eyes and eyelids, it may progress to blurred vision, and sometimes you may get an eye pain. Antibiotics are used to treat the early stages, but in the late stages, when effects have already occurred in the eye, they are not helpful anymore. That is when surgery is employed. And even surgery, like you all know by now, you've been exposed. Whenever you have surgery, there are usually issues associated with surgery. You may get a scar with its complications, or you lose a tissue. So think along that line. Access to clean water and improved sanitation are key to prevention. So this is a disease that is preventable by the least resources, just having water and soap and being motivated to clean your body, especially the face, is enough to remove trachoma from the community. And that's the reason I told that probably some of you, if not all of you, may never see trachoma in your lifetime, because at least now people have access to water and soap and they are affordable. So with the improved sanitation standards, people going to school, then this disease is really declining. So by the end of this lecture, my expectation is that some of you will know what trachoma is, what causes trachoma, the signs and symptoms, and the complications, because that's where the interest is. We need to know the WHO classification of trachoma, the 5 F's and the 5 D's, the treatment options, and there is that famous safe strategy. You cannot talk about trachoma without talking about the safe strategy, because it has produced tremendous results. You'll forgive my English, I come from Western Uganda, so it is so westernized. So it is derived from a Greek word meaning for rough, and then swelling. The swelling is rough. It's one of the most common diseases. And like we said, it is the leading infectious cause of blindness worldwide. And most common times, there is a standard definition of blindness that you should check out if you don't know by now. And it is estimated that about 150 million people have an active infection. If you don't know what 150 means to you, this is about 3 Ugandas put together, if not 4. And over 5 years, and over 5 million people are blind, or they have serious visual loss from trachoma. It is hyperendemic in poorest, for reasons that should be clear now, because we said it's a disease associated with poor sanitation, and it is in the most remote areas of Africa, where we are, Asia, Australia, and the Middle East. What all these countries share in common, they lie along the equator. As the sun shines every day, remember it shines poverty. For countries which are far away from the equator, as you're far away from the equator, your GDP increases, the economic status increases. So every time we get sunshine, you know it is shining poverty. In this picture, this is a cell, the normal cell. The purple that you're seeing, that is the nucleus of the normal cell. And then what you're seeing like beads or blueberries or whatever it is, that is chlamydia, the infectious agent that transmits trachoma, that causes trachoma rather. So Chlamydia trachomatis is the causative agent of trachoma. It is an obligate intracellular organism. The word obligate means it must stay inside the cell. It doesn't survive outside the cell on its own. It has no known animal reservoir. Therefore, trachoma is for humans. We don't know any other organism that suffers from trachoma, although they can spread the infection, but we don't know them suffering from what? From trachoma. It's of the chlamydia group, which have characteristics that are halfway between bacteria and viruses. There are three known species, which is Chlamydia trachomatis, Chlamydia psittaci, and Chlamydia pneumoniae. If you've been rotating on the words, especially children and elderly people, you know chlamydia causes pneumonia. So we can find it in the eyes, you can find it in the lungs. Psittaci also seems to be affecting the lungs. They are sensitive to antibiotics, especially the sulfonamides and tetracyclines. Like viruses, they can only live and multiply inside the body cells. Chlamydia trachomatis has 3 biovars, 2 of which cause human disease, the trachoma and then lymphogranuloma biovars. Within the trachoma biovar, the primary serovars responsible for trachoma are A, B, BA, and C. Serovars D up to K, D, E, F, G, as you move listing them up to K, are responsible or associated with genital infections. They may affect the eye. Even when they affect the eye, they don't cause the prominent scarring that cause the effects of trachoma, like the A, B, B, A, and C. L1 to L3 are responsible for causing lymphogranuloma tenereum. In its life cycle, there are 2 specialized forms, and this is something for you that you should always remember, because in examination they pick interest in it: the elementary bodies and then platelet bodies. So the infectious particle is the elementary body, but what survives in the cell inside your body is the reticulate body. This simplified diagram shows you an elementary body, which is the one that enters the host cell. It is taken in by endocytosis, and once it reaches the endosomes, it is going to quickly become active. This is inactive. This is the active form inside the cell, and it will change into a reticulate body, which is metabolically active. Metabolically active means that it is going to replicate by binary fission and they form more particles, which will be inside an inclusion cyst, because we are having the reticulate bodies which are active, and then they will even mature, they will grow, become big, then break into many elementary bodies. So this is a mixture of elementary bodies and the reticulate bodies. Well, remembering that the elementary bodies are the infectious particles, so they can leave the cell by exocytosis. They are shed into the surrounding and they can be picked up by neighboring cells. So the infection moves through the whole body. They have a unique development cycle distinguished by 2 forms: the elementary body, which is metabolically active, And we said it is taken in by invagination. Okay. So within about 2 hours of infection, the elementary body is transformed into a reticulate body. Within the next 15-30 hours, it's metabolically active. And in approximately the next 18-30 hours after the infection, the reticulate bodies begin transforming into elementary bodies. The reticulate bodies and elementary bodies remain enclosed in the inclusion, which can occupy up to the 90% of the cell cytoplasm. It means now other organelles are going to be pushed to the periphery. In about 40 to 48 hours post-infection, the cells will break up, releasing elementary bodies into the extracellular space to infect other cells. This is a diagrammatic representation of what we are saying. Just to catch up and to memorize visually, we're having elementary bodies on the susceptible cell. They are taken in by endocytosis. Inside, they are going to turn into reticulate bodies, which are metabolically active. They will divide by binary fission. So in about 24 hours, they are already many. So they keep on increasing in number. So you're going to have reticulate bodies and elementary bodies in a cell. Also, there is another pathway where these cells are going to exit the growth phase, and then they are going to just be dormant inside cells of the body. They will form the elementary bodies, and they will be, because we said elementary bodies are not quite replicative, they're a bit dormant, they are not metabolically active, but they will form like a reservoir. Anytime they can decide, they can be recalled back into the active form. So within about 72 hours, about 3 days. So from the time of infection, within 3 days, you have other cells are being affected because you're already shedding the elementary bodies, which are going to infect other cells. So how do we know that someone has a chlamydia infection? In the laboratory, we can have laboratory diagnosis. It is not a disease that is as easy to diagnose in the laboratory as other diseases, maybe HIV or malaria or what, but science is moving so fast. Probably we are going to have more effective and cost-effective and even specificity and sensitivity being high. Maybe we can roll them by bedside. So that is a hope for the future. But as of now, it is challenging. Most of it you'll be making clinical diagnosis, but however, there are lab ways of detecting the infection. So you can do cytology. Cytology means looking at a cell and then looking for the abnormal thing under a microscope, probably with special stains. So you can take conjunctival swabs and put on slides, go and study the cells. You can also culture the microorganism. So you can do tissue cultures. You can also look at the antigens. You can also look at the nucleic acids. Nucleic acids, if you're a student who is disinterested in microbiology and investigative, nucleic acids is the in thing as of now. That's why they're even to do the PCR for COVID and everything. So much of the investigation is going to go into nucleic acids. So in your career, you're likely to see much of this as we are moving away, probably most of the time, from the antigen or antibody. Antibody tests will at one time probably become obsolete in infectious agents. And then as more data and as we understand the genes, the genetics of organisms better, That's why we are saying the serological tests, that are the antibodies, are not helpful in this disease. So the direct smears can be stained with iodine or GEMSA. Iodine stains the glycogen mass of Chlamydia trachomatis, and the inclusion bodies will appear reddish brown. GEMSA is more sensitive than iodine. Both the elementary bodies and the tertiary bodies appear reddish purple. And other tests, we talked about them. You can tissue culture, whenever they culture an organism, its specificity is usually 100%, but usually what limits this methodology, apart from cost, is usually its sensitivity, but specificity is usually 100%. These ones we talked about them. You can do nucleic acids, you can look ELISA. So let us understand how the disease is in human beings, what we call epidemiology. We talked about these percentages: 21 people living with active trachoma, and another 2.2 million could be blind. And then probably 7.3 million people are suffering from trichiasis. Trichiasis is the severe form of the disease. We shall define what it is. Trichiasis as pertains trachoma, because once you have trichiasis, it is just a few days that you're going to develop blindness. We shall see the reason why. We said it can vary from mild disease, severe disease in different situations. The reason why this same infection can produce a mild disease in one situation and a severe blinding disease in another is due to the following factors. One, reinfection. It's a disease that you keep on being reinfected. And the organisms are not the worst enemy here. Our worst enemy is the inflammatory response. Just like in COVID, if you know, what usually kills the person is the amount of response that is mounted against the virus. Similarly, here in trachoma, the amount of immune response that comes due to the infection is the one that is going to cause scarring in the conjunctiva tissue. So every time you get a reinfection, it means you're going to get an immune response. You're going to have fibrin deposited there, which will lead to scars. Probably if you got one infection and it was treated and you went off, you wouldn't have any problem. So reinfection is the problem. Then if you're living in poor, overcrowded communities, poor, you can't afford, sanitation is basically bad. Overcrowded, we said it's a disease that is contagious, moves from person to person. So it means the chances of you getting the infection will be high. It majorly affects young children. Young children, because they have secretions, and then flies will come and they will, if you remember the initial picture, the pictures we saw, then a child will have flies, will not chase them. Children tend to be together at different times. They tend to have secretions from the nose, from the mouth. Even when they eat, food is going to be around. You know those children that are found in disadvantaged communities, how they look like. The commonest vector that we have is the flies, the big flies that you know that you usually find in restaurants, those of us who go eating where we can save. Dry and dusty areas simply because, one, there isn't enough water to promote sanitation. So you have a lot of dying rubbish in a particular place. So mosquitoes, rather house flies, can breed from those areas easily. So among the objectives, we wanted to know the 5 F's and then the 5 D's. So the 5 F's that are associated with the trachoma, we have flies, we said they are the vectors. We have filth, which favors the multiplication of the flies. Similarly, feces, they attract flies. So you're in a community which has poor fecal disposal, you have lots of flies because they will have breeding grounds. Then we have fingers. These fingers, again, you're going to touch, if you touch in the secretions or eyes of someone who has trachoma and you touch in your eyes, or for some reason you touch on a fomite, there is someone who had trachoma, they scratch their eyes, they touched on a door, on a doorknob, you come and touch on a doorknob, you don't wash your hands, you touch your eyes, so you're likely to get it. That's how fingers come in. Then the doorknob is the fomite. Flies, filth, feces, fingers, and fomites. In P3, remember, we studied about some Fs, were they 4 Fs and then later 5 that were sorted with the diarrhea. Today they come back when you're in 4th year. The 5 Ds, we have the density, which refers to the overcrowding. We have dust, we have dryness, we have dung animals, again, breeding grounds, sanitation, we have discharge from the eyes. If any one of you has a question how we relate to these ones to trachoma, we can discuss that. This is the same thing, basically. Again, these are the things we are going to look at. If you look at this child, you can see why flies are feasting on the guy. And if this person has trachoma, the fly will move from this child to the next child, or wherever this fly was coming from, they are attracted to this child. So in no way in a community that it has endemicity of trachoma will this child survive from trachoma. This pathophysiology in the initial slides that Dr. Sam shared with me, he had not put it there, but I put it for you here. If you have a minute or two and you read through this, it will stop you the burden of cram work, because it is it's well detailed yet precise to show you how the picture comes in for trachoma. So if you skip it again, it's up to your own peril, but I would encourage you to read it. But I've told you everything that happens. So what are the signs and symptoms of trachoma? Remember, we began by saying that it starts as a mild disease. The problem comes from the repeated infections, and then you get scars. And then after the scars, you get the anatomy distorted. The eyelids will turn inwards, something we call entropion. We know eyelashes are attached onto the eyelids. Then when the eyelids are turned inwards, the eyelashes will be forced to rub onto the cornea. When you have a sharp thing and keeps on scratching on a glass, probably the best thing would be saying like plastic. If you have a sharp thing scratching on plastic, you lose the clarity of the once clear plastic or even glass. So that's what happens. Even for those of you who put on specs, you know, when they are new, they are clear, but if you don't take care of them nicely, eventually your specs are going to get scratches. So that's how the cornea is. If eyelashes keep on rubbing onto the cornea, then you lose the clarity. So, but what are the symptoms and signs we see in trachoma? One, on the conjunctiva, we tend to see follicles. Now, it is of interest that in your life journey as a doctor, you know how to differentiate follicles from papillae. Follicles, they tend to be from lymphoid tissue. They're a bit yellowish. You see them like small growth from a normally flat mucosa. You start getting some outpouching, things which are looking like beads. So they're usually yellowish and they don't tend to have prominent blood vessels in them. As opposed to papillae, papillae tend to have a central blood vessel feeding it. Excuse me for that. So that's how you differentiate them. And the follicles, usually it's an indication that there is an inflammatory response, lymphocytes have invaded the tissue. So follicles are enlarged nodules of lymphoid tissue under the conjunctiva, epithelium, and papillae on the surface of the conjunctiva. Now, in trachoma, we tend to look for trachoma under the upper eyelid, as opposed to the lower eyelid. The upper eyelid is longer, so that means it is easier. If you know about surface area, if you increase surface area, then whatever you're dealing with is magnified. Now, for particular reasons, I want to say, much as I've said, much of the things in the trachoma concentrate on the upper eyelid. Follicles tend also to be in the lower fornix. Follicles tend to be in the lower fornix. For the words you see that will be either crowded or many or what, I just added them in the slides, in the original slides, for your own understanding, just in case. By the big words, they are the slides that were shared by Sam. So these are the follicles. If you look at them, this is an inflammation. So generally the whole conjunctiva is inflamed. This is the upper eyelid. These outpoachings here, they are the follicles. And I hope I inserted another picture of papillae so that we see the difference. So if you look at this and this, there is a difference. These ones, they tend to be larger, flat-topped, and usually, I don't know if it is clear to you, but each one of them will have a very central red part, which shows there is a feeder blood vessel. They tend to describe a pattern like this, that it is a cobblestone. They are like big, small pieces of stones brought together. While these ones tend to stand, they are solitary, each one wants to stand out on its own without a central blood vessel. They are a bit yellowish. These ones, they tend to be pushing on each other. So just to continue again, this is a person will come in, they will be complaining of eye pain, probably eyelids are swollen, but the whole thing, people will be just saying the eyes are a bit irritated. Very mild disease, slight itching, very slight discharge, slight redness. So that's why most of the people will stay in the communities without complaints. It may even resolve on its own. So we had two, we have follicles, we have conjunctiva, we have papillae. Now we are going to look at what happens in the cornea. The other one we said they are on the conjunctiva of the eyelids. Now let us see what happens to the cornea. In the eye, if there is one thing ophthalmologists respect, it's the cornea, because once you lose the cornea, you lose the vision. So on the cornea, we have superficial punctate keratitis. The word punctate comes from the word like puncture, like dots, like something is pricking. So it's another sign of corneal involvement. It causes corneal haziness, especially in the upper cornea. Upper cornea because of the upper eyelid. When you have blood vessels growing into the cornea, it is called pannus. These blood vessels, the cornea has no blood. It's not blood. It's not a vascularized tissue. So these blood vessels will cross from the sclera, the white part of the eye, onto the cornea. There is this thing called the Herbert's pit. Herbert's pit, or pits if there are many. These things are pathognomic of trachoma in the past. They are pits, so they are small depressions. When you see them, then it shows that the person has trachoma or has ever suffered from trachoma. So in this poor picture here, we are seeing superficially, we are seeing the cornea is a bit hazy. This is the upper eyelid. So this is the superficial punctate keratitis. These ones, the blood vessels should stop here on the white part of the eye. So once they close onto the cornea, then it's called pannus. And once blood vessels grow into the cornea, you lose the clarity of the cornea. That cornea basically is damaged. These are the famous Herbert spits. These dark outspots, they like being on the limbus. The limbus is the junction of the sclera and the cornea. You can see them again well magnified. If you look at the slit lamp, this is what you're likely to pick out. They show you someone has had trachoma, or they have trachoma, or the community has trachoma in them. This is tracheasis I was telling you. You can see the eyelashes have turned inwards and they are rubbing onto the cornea, and the cornea has lost its clarity. You can even see the blood vessels already invading the cornea. This is the picture of trachoma, and that's the danger of trachoma. So basically this cornea here, we've lost it. So because of the repeated infection, you're having fibrin laid and what, so there is fibrosis, you're going to lose the normal architecture of the eyelids. So the eyelids will be scarred, will get scars, especially the upper lid, and it leads to entropion. Entropion, the eyelids are turned inwards. Tracheasis, you have eyelashes rubbing on the cornea. And then you may also have obstruction of the lacrimal gland, the lacrimal passage. Once they are scarred, it means tears can no longer drain through the normal passages into the nose and swallowed. Now the tears will start draining onto the cheeks and falling onto your chest, attracting more flies. This is an example. This child has a discharge, but whatever it is, even if the eye had a discharge, it should be draining through the punctum here and another one here. But this is excessive, but who knows, even there is a lot of scarring, or crusts are covering here. So the excess, instead of flowing from the puncta, it is overflowing onto the cheeks. This is the scarring we are talking about. This one should be a normal, flat, yellowish surface. All these things you're seeing, these are scars, and they'll be there for life. So this is the scarring that comes alongside with trachoma. We are having ugly pictures here again. Entropion has set in, especially the upper eyelid. Some people, the corneas are lost. Just to make you feel annoyed about trachoma, something that is simple to prevent. So we want to classify trachoma according to WHO. Each of these ones have a meaning in the community, because why is WHO emphasizing this? If you went to the community and you found people with follicles, children with follicles, it means they have an active infection in the community. If it is intense, and the importance of finding out these ones, this is a treatable trachoma. If you find people already have scars, maybe they had trachoma in the past, it's no longer a problem. So you need to evaluate and see, do they need an intervention or not? Tracheasis and opacities, they're important because if it is tracheasis, you must deal with it. There are people you will save the vision. If it is opacities, either they have lost the vision for life, or you need to do corneal transplants. So it has an importance of your public health intervention of what to do. So again, I told you when things are small, it means I put them there for you to know, to understand better. WHO clearly defines what it is. If it is trachoma, if it is TF, you need to, someone must have at least 5 follicles under the upper tarsal plate. If it is trachoma intense, you need to have a lot of follicles and papillae, and they should be enough to obscure the blood vessels in the normal tarsal conjunctiva. It should be obscured. If it is scars, you must find the scars. If it is trachoma, tracheasis, you need at least 1 eyelash rubbing onto the cornea. And the same thing. So TT, you need at least one eyelash. Even if it is one eyelash that is rubbing onto the cornea, it means this person is at a risk of getting corneal opacification. Then corneal opacification is really the end result. That's blindness. This is the timeline of how things move. We start with an infection, then young children, old adults will get scars, then very old adults will get trichiasis, and then they will get corneal blindness. The same thing with the clear definitions, WHO also. This is why I would interest myself about WHO. I would interest myself knowing these ones, what they are. The diagnosis again, there is things we talked about. So we start about diseases to know either how to prevent them, how to treat them, or how to rehabilitate the patients who have suffered from them and gotten the effects. So how do we treat trachoma? We may decide to give topical drugs. Those are the eye drops. They are usually cheaper and reduced systemic side effects. This is a misnomer. It's not that there is no risk, there is a risk, but the risk is reduced. Topical antibiotic ointment is effective against bacterial conjunctivitis, which might be alongside the trachoma that we are dealing with. You can decide to give a continuous dose. You can decide to do intermittent. You give, you wait for a few hours, a few days, and give again. So if you do the continuous method of treatment, you give drops of ointment about 2 times to 4 times a day for 6 weeks. This is usually if someone came to Mbarara with the trachoma and is only one person, we would choose this one, the continuous one, because it's not a problem in the community. You know you're going to treat them for once and that will be it. There's no risk of reinfection. But for places where there is reinfection, where there is endemicity of the disease, the intermittent approach is a better approach, where we're going to use drops of ointment twice a day for 1 week. In a month, they use only for 1 week, wait for the next 3 weeks without putting. Then they keep on repeating for 6 months. What your interest is that you treat this person, you wait for them to get reinfected again, treat them again. So you're assuming that for the 6 months you're going to treat them, that's half a year. They will have had reinfected, and every time they get reinfected, remembering that you need about 3 days from the time of infection to the time of infecting the next cell. So you want to catch them in that you want that time infection to come, inflammation to build, and then you keep on treating. If you did this approach in a whole community, likely to eliminate the trachoma. You may decide to go systemic. This one is good for severe disease in case a patient comes and probably they started with trachoma from the genital trachoma, that they touched the genitalia and then ended up transmitting the infection into the eyes, or from the eyes against the genitalia. So you want to treat multiple body sites using one shot. What antibiotics do you have to choose from? I think the current in thing is azithromycin. You can use tablets for adults. You can use syrups for children. You can also do tetracycline ointment, very cheap, very affordable. You see, if you have been in maternity, every newborn child is given tetracycline eye ointment. They know some mothers harbor chlamydia in the genital area. This is what we are trying to avoid. So that was medical management. Then surgical management, you can do epilation, that is plucking the eyelashes that are touching on the cornea. Remember, they are going to grow again. So you need to schedule this patient to keep on epilating them. Don't epilate them and send them to community without calling them to see on them again. I'm usually good at percussing. If it was a session, I would probably, the unfortunate student, I would ask you how long it takes for an eyelash to grow back or any hair on the skin. But we know we've lost hairs, we've shaved, at least most of us do shaving of some parts of the body, be it on the head, be it on the legs. So we know how fast hairs grow back. That one will give you a clue on how frequent you should review your patients to make sure that the plaque of eyelashes have not grown back. You can do electrolysis. You use probes. You prick the root of the hair. It's easy after you burn it with those electrodes. They are easier to pull off, and then they take time without growing back. Some will never grow back because you may damage the hair root completely. That's what your interest is. Cryotherapy, every time you see the word cryo, you're using very cold temperatures to burn the tissue. So you may decide to look at a place that is this figure that is producing lots of misdirected eyelashes for you. You decide to scar that tissue to burn it off using very cold temperatures. You may decide also to excise because you have interned eyelids, which are also interning eyelashes. You may decide to do surgery and you change the direction of the eyelid to stop the eyelashes from rubbing onto the cornea. This is the lady who had her lower eyelids were turning inwards and the eyelashes were rubbing onto the cornea. She's had her surgery, so the entropion has been corrected. Now the eyelashes are pointing in the right direction. These are internet photos. I picked them from internet. I don't have any copyright, but since the owners were not asking for copyright, I shared them. I believe these patients consented. In the prevention of trachoma, we are almost winding up. There is the famous SAFE strategy. You cannot talk about trachoma without talking about the SAFE strategy. SAFE simply because letters were rearranged to make meaning, to talk to policy providers, to talk to lay people, even for us, the lazy students, to remember until we die. But otherwise, this is not, you don't follow the strategies in the order of the word SAFE. Probably even it's the reverse. So SAFE is for, S is for surgery, A is for antibiotics, FACE is for facial cleanliness, and E is for environmental change. If you're implementing this strategy in the community levels where you'll be or where you are, it starts with E. And when you're preventing trachoma, probably the best and people who do a lot is the community. You as the doctor at the end of the chain, you do very, very little, and probably even some of those patients, it's too late. So engage everyone in the community. Schools are the most important. Churches, local communities, local administrations, they are so important. So you start with environment. You must link with very many sectors in the community. Don't personalize it as health, like I told in trachoma. Health does very little. Health is about providing information, appropriate information to teach the community, but much of it is done by other bodies. For example, you need water ministries and the bodies to provide water to communities, to tell the community to use water. This water should be safe water. Back in the days when I was doing my undergrad, I was told that some of these diseases, actually it is the amount of water rather than even the quality of water. I grew up from a place where we used to fetch water from ponds, the same water cows were stepping in we are drinking from, the same water would come at the same time. Even when cows are drinking from there, you just use your hands, you pick the water and you drink. Some of us survived. So I was taught that it is actually the amount of water that matters. First get the water, then you can talk about the cleanliness. I believe if someone was about to die of thirst and you were walking by the roadside and you found a pool of water just next to the road, you would risk and drink it, hoping to live another day. So make sure water is supplied, and then make sure the water is cleaned. Then let people use the water to bathe their body, not only faces, but the face is the important thing. If you remember the photos of the children in the slides, then you need antibiotics to treat the ones who are infected. There is a program that came to eliminate trachoma in the world. The drug was made by Pfizer. It was being administered in communities. They were giving everyone, whether you are sick or not, putting drugs in the community. That's why trachoma is not so much prevalent. So for those who have interned eyelashes, then they need an corneal, then they need surgery. This is a picture to show you what goes in the community. People randomly go to communities if there is endemicity of the disease, giving out drugs. Is there anyone who is not mute? Because I'm getting feedback in my laptop. Kindly mute yourself. We are almost coming to the end. So azithromycin is a relatively safe drug, a long half-life. You just give one drug and that's it. You don't have to give repeated doses. It has done wonders and magic in these patients. So if you suspect trachoma in whoever you will be, just give someone a single dose of azithromycin, and you know you've done what? You've managed them. You don't even to do what to get worried. I guess we've come to the end, and the end I'll again end up showing. We grew up like this. Some of us, I don't know why we never got trachoma, but this one it was not unusual in our families and communities. The flies themselves are not the biggest problem, but should there be an introduction of trachoma in this community, just know the elderly people will end up with corneal scarring. This comes to the end of the lecture. We've perfectly used 1 hour. It was a short one. We can have a few questions coming up, and then we answer them. I see we have about 10 chats. I don't know if there are questions for me. I could go there and check. So kindly unmute yourself and you ask your question.
Yes, doctor. I wanted
Yes.
to know whether Pannas is the same as corneal injection, the one we see in anterior uveitis. Thank you.
Okay, thank you very much. Now, Pannas simply means you're having blood vessels growing onto the cornea. And like I told you, the clarity or the clearness of the cornea is because there are no blood vessels. Once you have blood vessels, you're going to pour in inflammatory things in the cornea. Where there is inflammation, you're going to lose the cornea. So rejection means someone has had a graft. Someone's cornea has been thrown away. They pick another cornea from a dead person, they put there, and this living person is saying, I don't want this new cornea. Probably along your course, you're going to learn about graft versus host, or host versus graft rejections. So a failure, you're putting there a graft, and the graft, the body is refusing it. This graft is not going to take. So they are quite different. And when you have Pannas on the cornea, there are high chances of rejection of the graft. I hope it's clear. Pannas simply means you're having new blood vessels growing onto the cornea. Rejection, you have transplanted onto the cornea, and the old cornea is refusing the new tissue that you have put there.
Doctor, I meant corneal injection.
Oh, thank you.
Uh,
Corneal injection, with the word corneal injection, if we mean that around the cornea, you're having blood vessels, you're having dilated blood vessels. If you look at the eye is going to be reddish, simply because the blood vessels are dilated, a lot of blood is reaching the conjunctiva. Remember, the conjunctiva is transparent, so you're able to see the blood vessels underneath. Once there is inflammation, the blood vessels are going to enlarge, and then more blood is going to come, so you can see it being red. So the difference between them is that Pannas blood vessels have crossed from the white, the sclera, onto the clear glass. That's Pannas. While corneal injection, you have around the limbus on the white part, not on the cornea, but on the white part, the sclera and the conjunctiva. You're having prominent blood vessels showing that there is active inflammation. Is that helpful?
yes, thank you, doctor.
You're welcome, please.
Doctor, there's a question in the chat. And meanwhile, as you check, I just wanted to confirm, are your biovars same as, do they correlate with strains?
Now, what biovars, serovars, it is it's showing like the organism in the genetic makeup of the organism. How different is it? How slightly is it? While for the strain, it means like the whole organism has transformed into a new thing. I must be having my rusty microbiology or what. I don't know how to put it very simple for you, but for a strain, the organisms tend to be now like more different. And what the disease one strain causes, the symptoms may even vary. Like the organism has completely moved away to a new shape. If strain A meets strain B, they may look at themselves as different organisms. But for the other one, it's just about the genetic makeup, but the whole organism has not changed so much. Probably that's putting face to shame for not knowing the right words to use right now, but at least it gives you a clue.
Thank you, Doctor. There are two questions in the chat.
Okay. There's one I'm looking at from Hobsing, I don't know if it's a question. So once someone has scarring of the eyelid without reinfection, does this automatically progress to trichiasis and corneal opacification and eventually blindness, or does it require reinfection? Thank you, Mercy Kobsinje. Now, even having repeated infections and corneal scarring is not automatic that you're going to get trichiasis and corneal opacification or blindness. So it depends on how much of the eyelid has turned inwards. Because the whole problem is all about the eyelid changing its shape because of the scars facing inwards and the eyelashes touching onto the cornea. So even one scarring might be enough. Tissues respond differently. So, but what the majority will say, like when you're doing normal distribution, the more infections you have. So if one infection brought scarring of turning of about 10 degrees, two infection brought 20 degrees. So if you get 10 infections, you have total turning of the eyelid. That's what it simply says. But even a simple scarring, you may get one infection, but you produce overwhelming tissue response, you get very bad scarring, and even the eyelids turn inward. So it's about individual differences, but what is clear is that the more times you get reinfected, the more the eyelid will get scarred, the greater will it be to turn inwards, and then you get trichiasis, corneal opacification, and eventually blindness. The other question, I can look for it. Someone was enjoying the morning sun. I think there is still some outside. Probably we are not so late for the morning sunshine. So I suffered severe trachoma during childhood, and my corneal refractive index changed for life. Now, without repeated infection, is there a chance of recovering from the refractive power again? Thank you, Guido Godfrey. So what it means that once you've had a change in your refractive powers, it means the cornea changed its bending, the amount of light it refracts, it bends. So you should have glasses sorting out much of your problems. If otherwise you can't go back, even with the treatment and what, once you've changed the refractive index of the cornea, you cannot go back. So you need something to be done onto your cornea. You can have spectacles like some of your colleagues are putting on glasses, or you can do even contacts. You can have contact lenses instead of putting on these ones glasses. You can have contacts, or you can even go for surgery, which they call LASIK. I think in Uganda now there's a center that is providing LASIK surgery to try and correct the effects of the trachoma. So, however, it is of interest that your scarring reached onto the cornea without causing opacification. Hopefully that one again gives a guide of what can be done. So someone wants to get leptospirosis. I don't know if there's leptospirosis in Mbarara. Okay, is that for the day? Okay, there are two more messages coming in. Okay. Okay, so I think the rest of the day, if they are questions or what, you can always send them in. Sorry?
How can we see the PowerPoint?
Oh, so how do I share the PowerPoint?
Yes. Should I provide my email?
Yes, you can provide the email. If you, let me type in mine here so that you can send in.
Okay, doctor.
Okay.
I've gotten it.
Thank you. So guys, have a nice day. Wish you the best. And
All the best.
let me just log out.